All right, have one more attendee. Hi, if you don't mind saying, just in case, I don't know if you were here in the last class, you can see me, but I can't see or hear you. So if you don't mind saying a quick hi in the chat, it allows me to know that I'm not alone in this world. Hi, Lindsay. Oh man, you're a trooper. So one of our attendees just had her baby on Friday. So Saturday, Sunday, Monday, you are 3.5 days postpartum and you're here. Well done. Well done. All right. Today we're talking all about pelvic organ prolapse. We will get started here. Okay. Now, before I go into sharing my screen, I do want to give you a sense. I just want you to have this in the back of your mind. I'm going to talk through the pelvic floor model again, just so you have this image in the back of your mind as we go through the presentation and we're talking about prolapse. So again, remembering what your pelvic floor entails. Pelvic floor includes right hip on the right side, left hip on the left side, sacrum at the tailbone and the back and the bottom. Whoop. That won't happen to your pelvic floor muscles, I promise you. All this, grab it, oy. Your pubic bone up front. All the red stuff are muscles like any other muscle in the body. And there are a series of muscles as well. They put your superficial pelvic floor muscles back here. Okay. The role of your pelvic floor muscles, one of their roles are to be able to protect your organs. Your bladder that comes up front here, your uterus in the middle, the rectum at the back. So again, it protects your organs. With everything we'll be talking about with pelvic organ prolapse, there's a structural change that's happened here, and the pelvic floor muscles are no longer able to support those organs efficiently. Okay, so I'm going to put my model down and I'm going to share my screen because then I shrink and we'll dive in. Okay. Okay. And move this over here. And present. All right. All right, so welcome to week 3 of pelvic health tips for postpartum recovery. This is not anyone's first time. So again, my name is Anne, I work at Agile Physical Therapy. I'm at the Palo Alto location. All right, and that's my family. All right, so like I said, we've already gone, hopefully you know enough about me at this point. I'm a pelvic health physical therapist. I love all things pelvic health. This is week 3 of our virtual class series. I'll talk about the goals for today. Oh, shoot, I didn't change that to week 3 presentation. Save some time for some Q&A at the end and we'll talk about next week's class. All right, so week 3, this is all about pelvic organ prolapse. If you've never heard the term before, that's okay. I'm going to talk about it. Let me go actually to our goals for today. I want you to be able to understand what it is, understand the causes, the risk factors, and the impact that it has on the body. I want you to be able to know how to check for it, okay? And learn some simple tips to be able to treat it. All right, so what is pelvic organ prolapse? This refers to a drop or a descent of the pelvic organs from their normal position inside the pelvic bowl. Typically, how folks will describe a prolapse, it feels like a bulge in the vagina. It's usually another way that folks will describe it to me is like it feels almost like a tampon that hasn't been inserted properly, so it feels like it's about to fall out. That's another way to describe it. And symptoms are usually worse at the end of the day. So there are different types of pelvic organ prolapse or POP. It can be the bladder coming down towards the vaginal opening more than it should. It could, and that's called a cystocele. It could be the urethra coming down into the vaginal opening more than it should. Usually cystocele and urethrocoele can go together. It could be the uterus coming down, the rectum coming down, that's called a rectocele. It could be an enterocele, that part of the intestines are coming down into the vaginal opening. There's also something called rectal prolapse. I'm just gonna move, I have my face right in the middle of my, my diagram here. Okay, so this is the bladder coming, pushing down in towards the vaginal opening this way. So that's the cystocele. It could be a uterine prolapse, that moving down, or it could be the rectum also moving down. That's a rectocele if it's moving in this direction. A rectal prolapse refers to it, the rectum is coming out through the anal opening more than it should. So that's different. Rectocele and a rectal prolapse are different from each other. But typically, I mean, a lot of times what we see, again, postpartum, it could be the bladder, the uterus, bladder/urethra, the uterus, or the rectum, all moving down into the vaginal opening. It's graded differently. It could be, you may hear terms of grades or stages. Either way, it runs from 1 to 4. 1 is least severe, 4 is most severe, and that's typically when surgery is more appropriate. Okay, so what are the causes and the risk factors of pelvic organ prolapse? A traumatic delivery is a big one. A lot, prolonged time in active labor, a lot of pushing can really be a big cause for it. An instrumental birth, so forceps more so than vacuum assisted, but yeah, forceps. I tend to see a lot of forceps deliveries that can result in pelvic organ prolapse, and also research supports that as well. Chronic constipation can be a cause or a risk factor. A lot of straining activities, again, bearing down into the pelvic floor, really having those organs not pushing down more than you ought to be, quite frankly, puts pressure of the organs down in towards the vaginal opening. A lot of weakness to the pelvic floor muscles can cause this. Having more than one baby and a hysterectomy can cause this as well. Now, the impact that this has on the body, it can result in pain or discomfort with sex. Again, if you imagine that cervix is down lower than it really should be in the pelvic cavity, so oftentimes my patients will describe discomfort when their partners, with any sort of penetrative sexual encounters. They can describe it as discomfort around their cervix because everything is just moving down more than it should be. Lower back pain can be associated with pelvic organ prolapse. Urinary problems can be associated with this. Chronic constipation. Last week we were talking, I think last week or the week before, we were talking about, again, between your bladder, your uterus, and your rectum, they're taking up the same space. Oh, they're all like sort of squishing against each other, supporting each other inside your pelvic bowl. So if you have constipation, where there's a lot more stool that's accumulated in your rectum, it does put pressure into your pelvic bowl, and that can be part of what causes issues with, or sort of persistence in a feeling of pelvic organ prolapse. This is particularly the case with rectocele. If you have the rectocele, again, referring to your rectum moving into your vaginal opening more than it should, and that's coming from the back of your pelvic bowl. You might not be able to see my pelvic bowl, so I'm not gonna bring that out again. But if you have a rectocele and you have stool that's accumulated in your rectum, and again, your rectum is not quite positioned the way that it should be, you could have some stool that's sort of accumulating over there. And you have more and more stool that's accumulating there, it can make the prolapse worse or more persistent. Vaginal bleeding and infections can also be the impact of POP. All right, so how do you check for pelvic organ prolapse? Yes, it's certainly easier when a provider can do it for you, but you can do it for yourself. I do recommend that if you're pretty newly postpartum, might not be the right time to check. I would say if this is something that you've been dealing with for a few weeks, a few months at the very least, it's a good idea to check. Different positions that you can try. I took this from a pelvic therapist that I like and really I follow on Instagram. My pelvic floor muscles is her handle. But a few positions that you could try. If you're lying down with your back sort of supported, you're sort of a semi-reclined position and your legs are supported, use a handheld mirror. You could reach down. And what you would do is bear down a little bit. So imagine that you are birthing a baby. So that feeling of pushing down, or you're constipated, push down, or you could cough. I personally prefer bearing down. Use the mirror and check to see if there's tissue that's coming towards the mirror. Again, some people have a hard time being able to imagine this, but when you're just looking at your when you're just looking at your vagina in general, you should be able to distinguish your urethra from your vagina itself and your rectum. If you're looking just at your vagina and you see an opening and you bear down, you see less of that opening and there's some pink tissue coming towards you, that could be part of a prolapse potentially. Okay. So you could check in a semi-reclined position. Here she's just talking about, use a mirror to check. You could also check in standing. This is a really functional way to check for pelvic organ prolapse. Like I mentioned, a lot of folks usually with this diagnosis can feel the effects of it at the end of the day, after being on their feet for quite a bit, doing a lot of lifting, pushing and pulling, taking care of the kids, etc. So, or they're exercising. So checking for it in standing and doing the same maneuver of bearing down is just a much more functional way to assess for it. All right, now to the nitty gritty. How do you take care of this? Pelvic floor muscle strengthening, positioning, using support, whether it's external or internal, and then lifestyle changes as well. So let's tap into the pelvic floor muscle strengthening part. Now with pelvic floor muscle strengthening, this is the #1 way to manage pelvic organ prolapse. Research supports this, that it will either minimize the symptoms with the consistency, it will minimize the symptoms of a POP, or it actually can even reduce the severity in the grading or the staging of it. So this can be incredibly effective. Now, I've given examples here. These are the variations of bridges or ways that you can do your Kegels, quite frankly, in bridge positions or kind of being in this sort of, what we call prone, lying on your belly over an exercise ball. Now, this does not mean that this is where you stop. In terms of how you would do your Kegels, you would want to progress certainly to being in a standing position, seated, doing very dynamic movements while you're doing the Kegels and your general core strengthening. I've listed these ones as a good start. If you feel like you have it and you want a place where you can start, the theme with all of these pictures is that your pelvis is a bit of it's in an unweighted position. In the next slide, when I talk about positions, I'll elaborate more on that. So bridges with your feet up on the wall, single leg bridges if you're feeling pretty strong and you want to advance, or bridges over a ball. Doing Kegels in this position is great as well because gravity is not working against the pelvic floor muscles here. So being in this position and then doing some Kegels can also be pretty effective. In an ideal situation, you're doing the Kegels and the core strengthening. I'm saying Kegels because I know that folks are have more familiarity with that word. But when I say Kegels, I'm really talking about your entire core, your abdominal muscles, getting that engaged with your pelvic floor muscles, syncing it with your breath in the way that we've talked about the last couple of weeks. All right, positioning. So you could do Kegels in any of these positions, having a wedge underneath your pelvis, putting your legs up on the wall, having a yoga block, or even just several pillows under your pelvis. Positioning is great because, again, most people with POP will describe it feeling worse. Again, that bulging sensation into the vagina, that heaviness or that pressure into the vagina is worse at the end of the day. So being in this position for 5 to 10 minutes, you don't have to do anything other than just hang out here. It's great. So again, the whole idea is to be able to pull your organs up and in, back into your body. So being in these positions to unweight the pelvis can be a nice way to just help reverse what gravity has done to your pelvic organs throughout the course of the day. Okay, I'll make sure I'm good at the time. All right, supports. So external or next slide, I'll talk about internal support. So external support can be really helpful. Support garments, underwear or outerwear. There are tons out on the market. There's one that I like, EVB Sports. They have underwear that you can use under your garments, or it can be essentially like, like workout gear, shorts, capris, leggings. This is a EV Sport is a UK based company. And I just realized, I just found out today when I was Googling them, Amazon doesn't have them in stock anymore. So all these compression garments can be a bit pricey. The reason why I like them in particular, because they offered the compression and they also offered perineal support. So hopefully you can see, and if you can't see, what I'm doing is, this is your pelvic floor muscles. This is, if you're in a position where you are lying down and legs are coming towards you, your perineum is right here. And what the shorts offered was an inbuilt pressure system that applied pressure right into here, right into your perineum, which can feel very comforting and very supportive with pelvic organ prolapse. Other garments that are out in the market, there's SRC recovery shorts, there's FemJock, there are a bunch of them. But the goal with any of these support garments, it should feel like it's offering compression. It could be into your abdomen and certainly through your pelvic floor, just feeling like it's lifting everything up. Now, internal support can also be very effective. This is typically if you have a grade 2, grade 3 prolapse. So it's moderate, mild-ish, mild to more on the moderate side. And really what it is it's a device that's inserted internally to, again, the whole idea is to lift everything up and inside your body. This is something that's done by your OB or your midwife, because you do need to be fitted properly for it. And these are just different variations of a pessary. Oh, and by the way, with pessaries, you can also do Kegel exercises with them. And typically when you're fitted, it's something that you have in for, it can be several weeks to a few months, and you go back to your OB, your midwife, to have it cleaned and put it back in. All right, the last part in terms that I want to talk about in terms of how to take care of yourself if you have pelvic organ prolapse is lifestyle or behavioral changes. First thing, I mean, weight management. The more weight that you have on your body that's putting pressure into your pelvic organs, the harder it can be to offer support to that. So getting into managing the weight appropriately is a good start. Avoiding constipation is really important. Avoiding straining. Anytime you put pressure down into your pelvic floor, down into those organs, it's doing the reverse of what you really want to be able to do in terms of recovery. You want everything to come up and in versus holding your breath, straining, pushing down. So if you do have chronic constipation, being able to manage that as effectively as possible with, your nutritional changes. If you have to have your physician be involved with that, that's also great. Thinking about your bowel habits. Avoid, like, constipation is its own sort of topic. So there are tons of things that you can do, but just know that management of it is going to be important. The other part too, in being able to make sure that you are inadvertently are not allowing a lot of stool to accumulate in your rectum, and that's part of being constipated, is actually doing some perineal splinting. A lot of folks who may or may not know that they have prolapse, but they already started to do this, is they would feel like their bowels wouldn't evacuate completely if they had more of like a rectocele, again, rectum coming down in towards the vaginal opening. So what they would do is use their thumb or 2 fingers and put pressure into the perineum, and the pressure would go, I'm so sorry, hopefully, I hope you can see me. I can show you this again and put a note in the chat if you can't quite see this, because I can show you again when I unshare my screen. So perineal splinting refers to using your fingers or your thumb right here on the perineum, pushing up and back. So you're pushing up and back. You've had a bowel movement, you don't feel like you completely emptied out your bowels. Pushing up and back with your fingers can help to move the stool that sort of could have, that would have accumulated in that pocket of that rectocele, can help it kind of move out, pushes back into your rectum so it can empty out completely. So perineal splinting is another very effective way that you can help to manage sort of any sort of accumulation as a result of accumulation of stool as a result of a rectocele in particular. Avoiding smoking is important as well, just in terms of the damage that it causes to the tissue quality. You want everything to be as supportive as possible. So if the integrity of your tissues is being altered as a result of smoking, that's important to consider as part of your long-term recovery. All right, so that is my information. And I'm gonna unshare my screen. Well, let me just do this and I'm gonna unshare my screen. So we'll go through any questions that you might have. Next week, we're talking about self-care tips for pain with sex. This is by far one of my favorite topics to talk about. So I'm gonna unshare this, stop sharing. Okay. Any questions? And while I give you a chance to type really quickly, just to show you again, hopefully this is a little bit larger so you can see what I was talking about with the perineal splinting. This is your pelvic floor, or this is my pelvic floor in this position with the perineal splinting. Again, this part represents your perineum. What happens typically when there's a rectocele in particular, that is the rectum is moving down towards the vaginal opening, so it's come forward a little bit more than it needs to be, so stool starts to accumulate over there. After having a bowel movement, using your fingers, whatever fingers feel more comfortable to you, it could be this, or it could be your thumb, you're pushing up towards your head and back a little bit, okay? The goal is just to manipulate the tissues so that stool, quite frankly, can move back into your rectum, because it ends up sort of pooling into a pocket as a result of the prolapse. So you want to move the stool back, and then you can empty out your bowels effectively. Because if you're chronically constipated because stool keeps accumulating, that can impact, it can impact the pop. Okay, so how soon can you have a pessary put in postpartum? Ooh, good question. All right, so the question is, how soon can you have a pessary put in postpartum? I would want, I mean, at least the very first 2 weeks postpartum, I would just wait. I would just kind of let your tissues, 6 weeks? Okay, so Zainal's also a therapist. She says 6 weeks, question mark, if it's needed. The first 2 weeks, I would just wait, let everything recover. It takes 6 weeks for your tissues to start to really kind of heal. If there was any scar tissue, quite frankly, as a result of a vaginal delivery, it takes the 6 weeks for about 75% worth of healing, quite frankly. 12 weeks for full, like 100% healing of the tissues. So Zainal makes a good point. I would say at least 6 weeks, at least 6 weeks. But even then, it would be really, yeah, it would, a lot of it would really depend on, you know, what happened, like during the vaginal, the delivery experience, your birthing experience. I want to know more information, but at the very, very least 6 weeks, I'll put it that way. Sorry, I hope that answered the question. All right, any other questions? 724, I'm so proud of myself, 724. Did good. Wasn't late. All right. Can things go back to 100%? I mean, that's a good question. I mean, over time, I mean, it really depends. I hate to say it, that it depends, but I have seen a lot of folks who've had some pretty severe prolapse and have done really, or is it something you deal with? Not necessarily. And none of this, with all of these topic areas that we've been covering from with postpartum health, there's not something that you should deal with. There's always something. There are always variations that, in terms of a treatment approach that we can put in place to help. So I've worked with folks with POP, some really, really severe issues of POP, you know, and combined with urinary incontinence and pelvic pain, et cetera, and who have done really, really well and gotten back to achieving goals of being able to exercise pain-free or symptom-free, et cetera. So it just depends. It might mean that if traditional Kegels and core exercises are not enough, then it means that, okay, maybe you are appropriate for a pessary. So we get that pessary, and then you do your workout. You do all of the exercises for the pessary, and that makes a difference. Or finding positions that you should start off with and being in that position and doing your core exercises for 2 to 4 weeks or something like that. Don't quote me on that, but for a good amount of time, and then progressing to something else. So it's not something that you should deal with. In your case, give it a little bit more time just for rest and recovery, and then getting into place, okay, you know, simple things with doing gentle core exercises, seeing how things feel like that, feel that way, and then starting to progress accordingly. Typically, when I don't see enough of a progression with exercises or something like that, or behavioral modifications, I always time it, give it about 2 weeks. If no changes, all right, let's try to bring in this, this, and this and see how things feel. But it's not something you should deal with. All right, any other questions for me? Cool. All right. Thank you all for joining me. This is great. Next week, we are talking all about pain with sex, okay? So if you have anyone that you think might be interested in joining us, it'll be the last of our series. Please have them, you know, send them the link. That would be great. If you have any further questions for me, please feel free to email me. My email is udofia, UDOFIA, @agilept.com. All right. Thanks, everyone. Have a great night.